Hello there. I am Dr. David Zhen. I'm an assistant professor at the Fred Hutchinson Cancer Center and University of Washington in Seattle. And I was invited by the LACNETS group to discuss a trial that I am leading nationally through one of the National Cancer Institute or NCI cooperative groups. One of these groups, their name is SWOG. And so I'm working with this group and here today to discuss brief aspects about this trial, SWOG S2012. This is a randomized phase 2/3 trial of first-line platinum etoposide with or without immunotherapy. And in this case, we're using a drug called Atezolizumab in patients with advanced metastatic, poorly differentiated extrapulmonary, in other words, outside of the lung neuroendocrine carcinomas. So I know that's a lot of words there. So hoping in the next few slides to explain a little bit about this condition, and hopefully it'll become clearer in the presentation. So first, before we can even get into the trial specifics, I want to give a brief background of how do we think about or classify neuroendocrine tumors and neuroendocrine cancers. And to that end, we want to talk about the classification in terms of when we get a biopsy, how do we separate or classify neuroendocrine tumors? And a lot of this comes from the World Health Organization, where they developed this kind of classification. And how I briefly think about it is that we classify them based on differentiation, meaning when we look under the microscope, we're looking at the shapes of the cells and asking, all cancers have to come from parents or normal cells. So do they still look like their parents? In other words, what we call well-differentiated neuroendocrine tumors, or do they not look anything like their parents? They've changed their behavior so much, they're much more aggressive. And that's what we term poorly differentiated neuroendocrine carcinomas, or NECs. And so when we use the word NEC, we're using it very different from what we classically think about neuroendocrine tumors, which are generally more slow growing, versus neuroendocrine carcinomas tend to be fast growing. Unlike in neuroendocrine tumors, we often rely on what we call a Ki-67, which gives us an indicator of how quickly the cells are dividing or how quickly they're growing. And in neuroendocrine tumors, we have a lot of different classifications. Some are slower growing, some are faster growing. But in neuroendocrine carcinomas, they're all faster growing. So basically, they're all high grade. But the distinction here is that they can come in two different shapes. So they're either small cell or large cell. So in other words, they're either small or they're large. And that's how we kind of classify them. Now, in terms of how prevalent this cancer is, this was a study done by Dr. Desari, who's a leader in the neuroendocrine field at MD Anderson. And he did a very nice review of what is the prevalence of neuroendocrine carcinomas, which is the focus of this clinical trial. And what I have here showing from his paper is that in the top panel A here, is that most neuroendocrine carcinomas actually start in the lung. And that the other term where we call that cancer is small cell lung cancer. But extrapulmonary is referring to neuroendocrine carcinomas that occur outside of the lung, which we end up seeing. And if we look at the pie chart here, if we take that about under 10% of patients who have neuroendocrine carcinomas outside of the lung, they often start in the gastrointestinal tract, GI tract. And as a GI medical oncologist, I see a lot of these patients, but they can also occur in different other areas. And that's what's in the pie chart in part B, is that outside of the GI tract, the other extrapulmonary cases can occur in the urinary tract. They can occur in the female genital tract for like the cervix and the ovaries. And then the males can also occur in the male genital tract, which predominantly often occur in the prostate. And then, as I mentioned, neuroendocrine carcinomas, we have two shapes of cells. So we have small cell and we also have large cell. And what the bottom left bars show here is that in orange shows the prevalence, or how often do we end up seeing small cells, versus in blue, the large cells. And what you can see here is that in most organ sites, small cell tends to be the more predominant histology, but there are some differences. So for example, in gastrointestinal tract, we often might see more large cells than small cells. And the reason I'm explaining all of this is because this is relevant to this clinical trial that I'm about to discuss with you. So in terms of what is our current outcomes with our current treatments and how we treat this very rare disease, which occurs in 1 per 100,000 patients, these extrapulmonary neuroendocrine carcinomas, is that we basically have treated it like small cell lung cancer, but for either better or worse. And the typical treatments that we use in small cell lung cancer is a combination chemotherapy regimen called Platinum, which usually there's two different drugs, cisplatin or carboplatin. So we just kind of group them into platinums. And the other drug is called Etoposide. And even though we've done this for decades, What we've known is that just like in small cell lung cancer, this table is basically outlining multiple different studies that have used this regimen in extrapulmonary or neuroendocrine carcinomas outside of the lung. And what you can see here, really the column I want you to focus on is the OS, the overall survival. So this is the length of time that patients live. And with our current treatment paradigm, unfortunately, this is a very aggressive cancer. And oftentimes we're talking about prognosis of about a year or less. So definitely much room for improvement here. Now, one of the big hypes is that many patients or providers are aware of what we call immunotherapy. There's a lot of different types of immunotherapy, but the drugs that we refer to are what we call checkpoint inhibitors. So really what these drugs are basically trying to take the brakes off the immune system and allow the immune system to work better and try to fight the cancer. And these drugs have been used in many different cancers, specifically relevant to this presentation, small cell lung cancer. So what I've summarized here is what is the data in terms of the use of single agent immunotherapy by itself. And what we've known in small cell lung cancer, and again, we kind of learn and use the treatments in small cell lung cancer. What you can see here is I don't want you to necessarily recognize all the numbers, but the point here is what we're looking here is what are the rates of shrinkage? What are the rates of keeping disease under control? What's the rates of keeping patients alive, their survival? And what we can see here is when we use these drugs by itself, oftentimes the rates of shrinkage are very low, 10% or less. We talk about survivals measured on order of up to 9 months. So again, outcomes are still very poor in this group of patients when we use immunotherapy by itself. We have very limited data in extrapulmonary neuroendocrine carcinomas, but likewise, we see the very similar lack of effectiveness. And so the take-home points from these last two slides is that using immunotherapy by itself in this disease is not going to move the bar. So where we might need to head is thinking about, well, how do we maybe use these treatments in combination? And that's basically where it came from data also from small cell lung cancer, is they looked at combining chemotherapy and immunotherapy together. And in this case, we're using a very specific immunotherapy, the immune checkpoint inhibitor Atezolizumab, where in this study in small cell lung cancer, what they did, this is what's called the Empower 133 study, where they randomized patients, in other words, half of patients basically got platinum etoposide, and our usual treatment is that we give that treatment for 4 cycles, so 4 rounds. And this is what's highlighted in the blue bars is the chemotherapy alone. And then if patients actually have control of disease after that 4 rounds of treatment, they get monitored. That was pretty much the standard of care. The experimental arm, patients got the immunotherapy plus chemotherapy together for 4 rounds. And if their cancer didn't grow, they ended up getting maintenance atezolizumab. So in other words, now we're using the immunotherapy to try to keep the disease under control for as long as we can. And the take-home point from this is that in small cell lung cancer, when we combine the treatments together, patients had a better chance of potentially living longer and keeping their disease under control for a little bit longer period of time. And so because of that, in small cell lung cancer, atezolizumab was FDA approved in March of 2019. And because, as I talked about in extrapulmonary neuroendocrine carcinoma, we use the same treatments for small cell lung cancer, the question comes down to, well, we should probably just be doing this treatment using the immunotherapy with chemotherapy as well. The problem with that kind of thinking is that, unfortunately, extrapulmonary or cancers occurring outside of the lung, these neuroendocrine carcinomas, the question is are they really the same as small cell lung cancer? So what we know in small cell lung cancer is that most patients get small cell lung cancer because of smoking. And when you smoke, it causes a lot of different changes to your DNA, or what we call mutations. And because of that increase in mutational burden or mutational load, that's where potentially why immunotherapy works. So the more mistakes that you have, it allows the immune system to recognize that. And then the immunotherapy really just kind of takes the brakes off and allow it to work. The problem is that in neuroendocrine carcinomas that occur outside of the lung, like the gut, the prostate, those are not really diseases that occur with smoking. So we don't see the same mutation rates. So the first question is immunotherapy going to work as well? And when we think about neuroendocrine carcinomas that occur outside the lung, a neuroendocrine carcinoma that starts in the gut is not the same as the neuroendocrine carcinoma that starts in the prostate. So for example, in the prostate, oftentimes what you have is it starts as a traditional prostate cancer and then becomes a neuroendocrine carcinoma, versus in GI, they start as a neuroendocrine carcinoma. And so the question is, when you've got those different components, how does the treatment actually affect that? And then I showed you the data on the prior slides that single agent immunotherapy doesn't really have a lot of benefit. And in all the small cell lung cancer trials, we just automatically give the atezolizumab after the 4 rounds of chemotherapy and immunotherapy to try to control the disease. But that was just an automatic assumption that would be helpful. We actually don't really have high-level evidence that giving that one agent of immunotherapy is actually going to prolong disease control. And obviously, if we don't have that data, we want to know, is giving the extra costs and giving the potential side effects of immunotherapy for a long period of time worth it? And so with all those considerations in mind, that's the purpose of this trial that I'm leading nationally. So this trial is SWOG S2012. And basically what it is a randomized trial, and it's dedicated for patients with extrapulmonary, in other words, occurring outside of the lung neuroendocrine carcinomas. And this is designed for any area in the body outside of the lung. So it can be in your liver, it can be in your gut, it can be in your prostate, it can be your bladder. It doesn't really matter. It's just as long as it's outside of your lung. And it really is trying to ask the question is, what is the benefit of adding immunotherapy to this disease? And the reason I explained to you about the small cell and large cell is that initially when this trial was opened in December 2nd, 2021, when I had designed this trial with the NCI, we limited only to small cell. And the reason for that was because there was another national trial being run, and we didn't want it to compete with the other study. In other words, have patients trying to decide which trial to go to, and this was a rare patient population. But that other trial has since closed. And so basically, I've amended the study or changed the study to allow everybody. So whether you have small cell, if you have large cell, if you don't get it called out, it doesn't really matter. So as long as you have a diagnosis of extrapulmonary neuroendocrine carcinoma, so in other words, we'll be able to broaden the number of patients who may be eligible for this trial. And we're trying to be broad in terms of basically what's the criteria to make you eligible. So as long as you have this disease that's biopsied, as long as your health is otherwise generally okay, you're eligible for the study. And in this study, there's a randomization. In other words, the physician and the patient doesn't get to decide, but by random chance, you get into one of 3 different arms. So you might see 2 of the arms that were done in the small cell lung cancer study. So the bottom one is just the standard of care of what we're doing right now, where you get 4 rounds of chemotherapy by itself, followed then by monitoring if your disease is stable, versus the experimental where you get chemotherapy and immunotherapy together. And after 4 rounds of your cancer stable, you get the atezolizumab by itself. But the third unique arm that has not been studied in the other studies is this red one, where basically now we're just giving 4 rounds of chemotherapy and immunotherapy together. And then if you have stable disease or no worsening of your cancer, we just observe you. And the point of this is really trying to formally answer the question, what is the benefit of doing that long-term immunotherapy by itself? And I think what the other part that's exciting in this trial is that we're also trying to better learn, because we have very little data, of in which patients are more likely to benefit from immunotherapy versus not. And so what we're doing in all of the patients here is we're taking tumor samples from all of these patients, and we're actually collaborating with 2 lung cancer oncologists at MD Anderson, Drs. Carl Gay and Lauren Byers. And what they did was that in the original small cell lung cancer study, they identified several different proteins, or what we call transcription factors, that we can identify just based on the tumors themselves. And what they saw was that depending on which transcription factors or which proteins were higher or were lower, it could predict your benefit potentially to immunotherapy, and also potentially could predict the benefit to chemotherapy. And so what they really want to explore is, does this also translate to neuroendocrine carcinomas outside of the lung as well? And so we're very excited that we'll have this kind of work that hopefully will increase our knowledge and also to better develop future trials and future treatments for this rare group of patients with very aggressive diseases. And that's basically the summary of our study. I just want to highlight that it takes a village to get this study going. And so this is just a slide highlighting a lot of different people from a lot of different groups who were involved in getting the study forward.